All right, here we go. Hyperlipoproteinemias, there are 6 of them. Good news, we're only going to talk about 2, because they're the 2 biggest ones, okay? Many, over 10,000 studies have shown that there is an association between atherosclerosis and plasma lipids, whether it's cholesterol or triglycerides. I don't think anybody's going to argue too eloquently that there's not, because there is a relationship between them. The reason that these are inherited, the reason that they're put into these categories is because management largely depends on which phenotype you have. That's why it's done. And we're just going to talk about 2 of them. But before that, there's a little terminology. Hyperlipidemia means an increase in triglycerides. You've probably seen this on your own blood. If you had maybe eaten breakfast or eaten lunch, we do our vena punctures and we spin it down. If it looks cloudy or milky, that's triglycerides. That's actually chylomicrons that you're looking at there. It's called hyperlipemia. Hyperlipidemia means an increase in any plasma lipid. So that would be an increase of cholesterol or an increase in triglycerides. And hyperlipoproteinemia means an increase in your lipoproteins. So LDL, HDL, VLDL, stuff like that. So the words kind of look the same, but they mean different things. I think I'll skip the next little blurb there. You can read that to yourself. So, like for when we did it, we want to emphasize to the patient that we want them to be on their normal diet. So if they have decided to be really healthy, but just to study for the test, we don't want that. If they've had a major illness, like a heart attack, something like that, or they've been on a big bender, we don't want to test it then. We want their normal lifestyle. So the very first one here is called type 2A. Hyperlipoproteinemia type 2A. Its second name is familial hypercholesterolemia. So this is cholesterol, high cholesterol that runs in craniums. So type 2A is the same as familial hypercholesterolemia. This is the second most common of the hyperlipoproteinemias. It's quite common, right? This is transmitted, doesn't really matter, it's an autosomal dominant. If you have 2 bad genes for this, so you have homozygous type 2A, you usually die before age 20. If I get off of my notes here for a second, when people were figuring this out, one of the major clues that there was something about cholesterol and coronary heart disease came from children as young as age 2 having heart attacks and dying. And what they found out with these kiddos is that they had super high cholesterols of 600, 800, 1,000, things like that. And those were researchers that put that together that, there must be something about cholesterol and coronary heart disease, which previously people just didn't really understand that those were even related. So homozygous, you got 2 bad genes. Usually these are people that have early death in their 20s from coronary heart disease. If you're heterozygous, you got 1 good gene, 1 bad gene. These are usually people who have a coronary event, usually around 50 or so, often a fatal heart attack in your early 50s. And again, it's the second most common hyperlipoproteinemia. So the next thing, I have a feeling you're going to maybe sit for a while. So you get the words, but let's think about what the deal is here. I'm really convinced if you understand how something works, that's physiology. If you understand how it doesn't work, that's pathophysiology. You can just guess what has to happen in the lab. So here's the pathophysiology here. It's a delay in the removal of LDL due to a lack of what is called high affinity LDL receptors in the peripheral tissues. So let's try that differently. In your peripheral tissue, you have a cell. And on that cell are receptors. So we'll pretend they're like little things sticking out there. Okay, so you've got these little receptors. Those are called ApoB receptors. And what they're supposed to do is you've got the cell with a little receptor on it. LDL is floating through your bloodstream. It hooks onto this receptor. This receptor brings it into that cell, and then it's removed from the peripheral blood. That's what's supposed to happen. So let's say we're supposed to have 5 of those. right? So for people with type 2A, they've got 1. So you've got a lack of these high affinity ApoB receptors. They can't remove LDL. Think about it. What should happen to that patient's cholesterol?
Increase.
Goes up. What should happen to their LDLs?
Increase.
Goes up. Look, there it is. It's right there in your lab findings, right? So if you understand how it works, you can just figure out what the labs are. So that's the etiology. They can't get rid of LDLs. The epidemiology, heterozygous is about 1 out of 500. Homozygous, thankfully, is about 1 out of 1 million. People has the homozygous one. Some signs and symptoms of it, some is none, but one is xanthelasmas. Xanthelasmas are eyelid xanthomas. What? So xanthomas are localized collections of cholesterol. And the evil terminology people decided we need to have a new name for these. So when they're on your eyelids, and it's usually on the inner, on below, and on top, they're soft. If you were to touch them, they're kind of yellow looking. They're called xanthelasmas. Xanthelasmas are the most common physical indicator that somebody has type 2A. Patients hate them. They just hate how they look. They've got these little yellow plaques on their eyelids, and they will have them cosmetically removed. They will come back though. If you don't take care of that underlying problem with cholesterol, the xanthelasmas will come right back. Xanthomas like to hang around extensor surfaces for people with type 2A. It's very common to see it on the back of the hands, on the extensor tendons. Very common to see it on their elbows, on the forearms, knees, Achilles tendon, stuff like that. They're soft. They're, if you can see them, they're a little bit yellow. They're called xanthomas. Arcus juvenalis is Arcus similis in a younger person. So Arcus, I'll draw a picture of it for you. You guys probably remember what Arcus is. A bad picture of an eyeball. There's a nose to open. Arcus, as we get older, we just get this lipid degeneration, and it looks like kind of a clear little circle that you can see in the eye. So you can usually look at older people and you can see that they have an arcus. Perfectly normal in an older person. Arcus juvenalis is when you see this arcus but in a younger person. And that's a pretty good clue to somebody with type 2A, usually before the age of 50. If you've seen arcus before 50, it's probably type 2A.
Is there usually a specific color to the art?
It's clear.
Clear.
It's clear. I'll show you pictures. I would call it up right now. Remember which PowerPoint is stuck in it. It's clear. It looks like a clear line circled around the colored part of the eye.
Does it have to go the entire circle? Does it have to go around the entire eye?
As far as I know.
Okay.
It's a really good question. I've never seen a partial arcus, but that doesn't mean that it can't happen. Because you would think as it's developing, maybe it starts at 12 o'clock and works its way around or something. That I don't know. I'd have to Google that. I will look. Other is just signs and symptoms of coronary heart disease, arterial-breweries, claudication, and accelerated atherosclerosis. So there would be early onset myocardial infarct, strokes, angina, stuff like that. So those are your signs and symptoms. As far as the labs go, I want you to know a little more detailed than just that the cholesterol goes up. It's increased because of the increase in the LDL. If it's somebody who has homozygous genes, their cholesterols are between 500 and 1200 milligrams per deciliter. Again, I'm hoping you guys won't take a patient whose cholesterol is 800 and talk to them about exercise and red rice yeast. I want to rename that to something else. Drinking wine, stuff like that. It's clinically inappropriate when it's that high. So homozygous, we expect 500 to 1200 for cholesterol. That's really high. Heterozygous is usually 250 to 500. Okay? I would like you to know those numbers. I would like you to get very good at figuring out cholesterol, what's a bad diet, what's type 2A, what's type 4, stuff like that. Your triglycerides are just fine and LDLs are too high. If you have an LDL over 190, A, way too high, B, type 2A. There's just very little, can't think of anything that would make an LDL over 190. If I see 190, it's pretty serious. It's very high. Okay? Those are your labs. Genetic, we manage it. We don't get rid of it, we manage it. So here we go. Couple of preview points. For every 1% decrease you can get in cholesterol, your risk for coronary heart disease drops by 2 to 3%, depending on if you're a man or a woman. So every little tiny bit is a good thing. Secondly, I'm at the guidelines level here. So I'm not talking about any of you guys just having high cholesterol because you like to eat bacon or something like that. I'm talking about patients who have type 2A. So not the general population of patients. So here we go. If the LDL is over 160 or the HDL is less than 30, it requires intervention. What does that mean? It means you don't just get those labs back and go, let's check that next year and see what happens. You have to do something. There's a lot to choose from, but you have to do something. So some of the things you can do, probably the biggest thing people do is called a two-step diet. There's a couple to choose from. One is from the American Heart Association and one is from the National Cholesterol Education Program. They're very similar. I think they're very doable, and I think it's a good thing to talk to patients about them. So what is it? So the first step is to decrease your total fat to 30% of your kilocalories. That is kind of a dumb thing to say to a patient. Right? So just walk into a room and say, you need to decrease your fat 30% of your kilocalories. Some patients don't even know what a kilocalorie is or what fat is. So you need to do a little bit of educating on that as to what does that look like? Where's this fat coming from? So that. Second is a 1-to-1-to-1 ratio of monounsaturated to polyunsaturated to saturated fat. Also kind of a dumb thing to tell a patient, right? You need to start with what's a saturated fat, what's a monounsaturated fat, what's a polyunsaturated fat, how do I get this 1-to-1-to-1 thing? We don't really have a problem with too much monos in our diet, right? So what you want to go after is this is what fat is, this is what's saturated, this is poly. I usually tell people start learning to like olive oil. Get some canola oil, start cooking with it. Anybody in here know canola oil? What it stands for? There's got to be one in a group of 60. Is it one? No, that's common. Well, all of them are a blend of the three groups. Anyone from Canada? That's one.
I'm not sure though.
It's called the oil of Canada.
Never heard of that.
We go home and say rapeseed oil is what the oil is, but it's called canola. It stands for the oil of Canada. So it's really high in monounsaturated fat. It has a pleasant taste. It's not really strong like olive oil is, or peanut oil, which has also got a lot of monounsaturated fats in it. So I usually tell patients, get some, buy some, and start cooking with it. If you look at people of probably my mom's generation or so, the way they cooked was to take a stick of butter. Well, first, what they did is fill up a pan of water and started boiling vegetables so there was nothing left in there by the time you ate them. Secondly, they would take a stick of something and put it in a frying pan and start frying stuff up. So that head, right, thinks that taking something liquid oil and putting it into is bad. That's even worse than taking a stick of something and putting it in there. So you got to do some undoing people's heads and saying it's actually better to take this liquid oil, use a little bit of it to cook with, and then there's different ones to choose from. Oils get rancid, so I'll buy smaller ones. It's probably enough on the 1-to-1-to-1 thing. Eating cholesterol isn't a real super big deal because it's not eating cholesterol to make cholesterol go up, it's eating saturated fat. But if you have type 2A, they do limit it, and in step 1, they limit it to 300 milligrams a day. It's okay to say 300 milligrams a day, but then you should give them some examples. This is how you read a label. This is what an egg has this many milligrams. So if you're eating a 3-egg omelet every day, you are getting 2, 4, 6, 700 or so milligrams of cholesterol a day. So just be careful. Eggs are great food, don't get me wrong. Great food, cheap protein. Fiber more than 20 grams a day, 6 of it soluble. It's the soluble fiber that's going to bind onto that cholesterol so that it can be excreted. most Americans, you want to take a shot at how much fiber they get a day? Oh, I'll make it easier. Do you think they get 20?
No.
Not even close. So again, I think it's educating patients about what is fiber. This is soluble fiber, this is insoluble fiber. They're both good. Get them into your diet. I usually tell people go after Cheerios and oatmeal. It's great soluble fiber. Drops my cholesterol pretty nicely. If you get 6 grams of soluble fiber every day, it can drop your LDL by 10 to 20%. Sometimes that's just enough. It's just enough to get you down to where we're kind of happy about your cholesterol. The third part is not diet, but it's exercise. And they would like you to exercise, preferably on every day of the week, 30 minutes. Okay? Some will say 20 minutes 3 times a week. And it's to increase your HDLs. The HDL that's increased with aerobic exercise is HDL2. I don't care that you know that. It's just much more cardioprotective than the stuff from drinking alcohol. So there are patients who would prefer to drink alcohol over exercising, but exercising really gets the HDLs up where we want them to be. So you do that. That's step 1. You have a patient do that for 4 to 6 weeks. Check it. If they're going the way you wanted to do, check them again at 3 months. If they haven't achieved where you want them to be, you go on to step 2. And step 2 is just more restrictive. So instead of 30% of your kilocalories coming from fat, it drops to 25. Instead of 10% coming from saturated fat, it goes to 7%. Instead of 300, it goes to 200 cholesterol. So it's just a little bit more restrictive. And you do that for 3 months. So how many months have we got there? 6 months. That's people with type 2A, a genetic problem. 6 months of dieting and lifestyle first. Then you talk about drugs. Okay? I will tell you, you won't practice more than a week, week and a half before you have a patient who goes in and is immediately put on a statin drug. These aren't my guidelines. I didn't make them up. This is American Heart Association and CEP. They're their guidelines. They say 6 months of therapeutic, it's called therapeutic lifestyle changes before you think about chemotherapy. There's a lot of people that just knee-jerk into a statin drug. Time for a story, quick one. Not gonna get as far as it's gonna get today. One of my brothers, for his second wife, she said, sure, but you have to go see a doctor. He hadn't seen a doctor in forever, right? This, I have to tell you a little bit, my brother used to smoke. This was one of his most favorite foods: white bread, mayonnaise, potato chips, the other piece of white bread. So, no exercise, well, high stress kind of guy. Went to see the doctor. Cholesterol was a little bit high, not bad, a little bit high. And he left the office with a script for a statin drug. What's wrong with that picture? He didn't address that sandwich. He didn't address the smoking. He didn't do it for 6 months. He just went, here's your statin drug, go away, you'll be fine. That's their guidelines, and I think we should take them too. Putting myself on a little soapbox for a second. Red yeast rice, I might have said that wrong, but it's a plant sterol that works just like a statin drug, just like a statin drug. So if you do the same thing, and if you have a patient who comes back, take my brother, bad the potato chip sandwich, and you say, here, take this natural substance. That's no better than a medical doctor prescribes a statin drug. 6 months, diet first, diet and exercise. Then you start in with the chemotherapy, okay? Most people don't do that, but that's what they're supposed to do. So, enough on that, off my soapbox, that's step 2. Specifically to increase your HDLs, stop smoking. So when I talk to patients, I usually go after one big thing that bugs me, and it's consistently smoking cessation. There's some evidence that says exercising is a better thing to talk about than smoking cessation, but I still start with smoking cessation. So it will increase your HDLs by a good 10%. It's a good thing to do, and smoking is not good for you in any way, shape, or form. Losing weight. Every 6 pounds of weight that you lose, however you want to achieve it, will increase your HDLs by 1 milligram. That's a pretty good thing. So if you're at 39 and you just need to get to 40 so that you're not at risk, lose 6 pounds. Regular aerobic exercise, I already talked about that, but it increases the HDL number 2, which is the more cardioprotective form. Every day of the week is the best. If you do that for 2 months, your HDL will go up by 5%. Okay. Treat hypertriglyceridemia. This thing goes past everybody's head all the time. They're inversely proportional, myself included. I'll look at some labs and go, why is that HDL so low? It's because their triglycerides are so high. So if we can get those triglycerides down, the HDLs will go up. So go after the triglycerides. It's inversely related. Blood glucose is kind of the same deal. If you control blood sugar because it has a lot to do with your triglycerides, that will help with your HDL. Monounsaturated fats are really helpful for increasing your HDLs. What are 3 really good sources of monounsaturated fats?
Olive oil.
Olive oil is one. Maybe. I was thinking coconut oil is being pretty saturated. So, that could be wrong. I was thinking it's saturated. Canola. Peanut oil is pretty good too. Peanut oil is pretty good for monounsaturated fats. All of your fats are a blend of all 3 of them, but some of them just have higher percentage of certain fats. Light alcohol consumption, I talked about before, if it is clinically indicated isn't the word I want. If a person shouldn't be drinking alcohol, you shouldn't tell them to drink alcohol, right? They like to drink alcohol, you can give them permission to have light alcohol consumption. Red wine beats white wine, and beer and whiskey are kind of neck and neck there. So the point is not overindulgence, light alcohol consumption. Omega-3s, way better for triglycerides. It would be my last choice for somebody's cholesterol to put them on omega-3 fatty acid. Guidelines, almost all the guidelines that I know of say it's better to eat fish twice a week than to take them by mouth. Now for people with severe heart disease, they take massive amounts of fish oils by mouth. That's HDL. Yes?
Can you repeat what you said for weight reduction for every 6 pounds that increases HDL by how much?
1 milligram. For every 6 pounds that you lose, it will increase your HDL by 1. So, the point being, even if you don't know the specifics like that, is that we're not asking people to drop 100 pounds. We're not asking them to completely change their lifestyle and have a burger again or something. Little changes. Learn to like oatmeal. It's kind of a new thing.
Dr. Raj, I have another question.
Josh.
for you. Back when we were talking about your 2-step diet,
Yep.
Is the goal to get back to like less than 160?
Yes.
Like that's what our goal is
Yep.
to get back to?
Yep. The goal of those is to get it more manageable. So if you're at 190, you might be looking at a drug at some point. But they still want to start with diet, therapeutic lifestyle changes, because sometimes they can bring it down to where they need it to be. If it's homozygous, it's no way. I mean, I've never seen a person, never heard of a person with homozygous. It's 1 in a million. You have to, that one's not coming down on diet. But heterozygous, you can do some pretty cool stuff to get them down like that. There was, Rachel just a second, there was a proposed guideline, which never passed, thankfully, that would have put every man, woman, and child in America on statin drugs. That's, we don't have a statin deficiency. So don't get me wrong here. There's other things you can do before you go on a statin drug. Rachel?
I just needed to know, under the increased LDL, I have greater than 190 is A, and then B was type 2A. What was the greater than 90? What was the, you said A and B. Greater than 90 was, and then you said type 2A was the other reason to have increased LDL.
I don't remember it. B, I can remember saying it, but one, I remember saying A and B. 190 is type 2A.
Oh.
It is not dietary indiscretion. It's not lack of exercise. An LDL of greater than 190 is the person with type 2. You even remember kind of long as that. do some specifics here. The National Cholesterol Education Program has what's called therapeutic lifestyle changes. It's an acute TLC, and but that's the same kind of specifics. Those are things that you want to talk to your patients about and how to get to them. So I have talked to patients about, you don't have to give up chili. We can just make it better. Okay? I think patients, when you tell them hamburger, which is a delicious thing to eat, a hamburger, no matter what you get, is a quarter fat. Okay? So you shouldn't be eating it every day. It should be kind of a treat. So yes, you can still do that. Just kind of be careful. So emphasizing vegetarian, meatless Mondays, eggless, cheeseless meals, and if you can't do that, at least look at portion control. So instead of maybe handfuls of grated cheese, measure things out. So get good stuff. Diet, to me, personal opinion, diet cheese tastes like chewing on cardboard. Get the good stuff. Get the good stuff and use less of it. The tasty stuff. Because butter and margarine is coming up, so I'll get to it when it gets there. Limit sources of saturated fat. And again, we're talking about people who have type 2A, not you guys, but people who have type 2A. So they shouldn't be eating organ meats, liver, brains, testicles, stuff like that. Cream, butter, lard, indiscriminately. For one thing, it's fat. We'll make it fat if you eat too much stuff like that. Red meat, good news, cows are skinnier than they were in the 70s. And so the data from the 70s was based on pretty chubby cows. The cows are skinnier. They found that cows have red meat from cows with stearic acid, which is pretty heart friendly. It's not a license to eat red meat 3 times a day. But you do have to kind of watch the portions that you eat. Eggs, they've done some interesting stuff with eggs. They used to think eggs contained a lot of cholesterol, and they actually studied it. And they found that an egg probably contains about 200 milligrams or so in the yolk. Eggs are probably nature's most perfect food as far as what's in there. Very cheap source of protein for people. You buy a dozen eggs for 79 cents, something like that. It's usually what we do to them. So if you're doing a hard-boiled egg, it's fine until you put mayonnaise on top of it, or if you take an omelet and then put a bunch of cheese on it. So the egg itself is actually not, I think it's perfect food itself. Skim milk versus whole milk. Whole milk is 4% butter fat. It's got a lot of saturated fat in it. It's, in my experience with patients, it's very hard to go from whole milk to the blue stuff, just like in one fell swoop. So I usually say go from whole milk to 2%. That seems kind of doable. It still kind of tastes creamy. And then they have a lot of trouble going from 2% to 1%. It just seems like, so I have them do 1.5%. So you buy a quart of 2 and a quart of 1 and mix them up. And then you get used to 1%, and you go down to the blue, and you'll never go back. And if you accidentally get from 1%, you go back. I've had, women can be like this, they can be tricky. And they're like, I'm making you your omelet, honey. And they'll crack like 3 eggshells, and then the eggs with the eggshells 2 go away, or the eggs with the eggshells, so it looks like that. They have a carton that says whole milk, but they are tricky and they put 2% in there. So be tricky with people if you want. So anyhow, get down to skim milk. Margarine versus butter. Here's the deal. Use less of both of them. They're 100% fat. So if you're using many pats of butter a day, it's actually a lot of saturated fat for somebody who's got type 2A. Margarine has evil trans fat. So I don't think it's a good thing to do. There's some plant sterile butters or margarines or spreads that aren't too bad. Just use less. I like butter on popcorn. I like a lot of butter on popcorn. I like butter on corn on the cob. I'm not going to suffer by putting something on there that I don't care to taste for. So use less of it. Just use less. Fish and poultry consumption should go up. That being said, state of Minnesota, the Department of Natural Resources, you can go to their website. It will tell you how many fish out of each lake you can eat because of pollution. So if you live on a lake and you're eating the fish from that lake, you need to be aware that the DNR has guidelines for how much fish you can eat out of that because of pollution, so be careful with it. They keep going back and forth with poultry about skin on, skin off before you cook it. I think the bigger thing is don't eat it. Don't eat the skin.
Do they usually talk about the mercury content in fish too?
The DNR?
Yeah.
The bigger the fish, the more mercury it is. I don't know if our DNR does or not. Like, the amount of mercury is going to be very hard for us to clean up the environment. The bigger the fish is, I don't know what the biggest fish you can get in Minnesota, but you're not catching a shark, I hope. Right? So it's the big fish eating the little fish. What a great song. Baby. Now that's in your head, you're welcome. It's a great song. I don't know. I honestly, I don't know. So where was I? Oh, don't eat the skin of the poultry. That would be a bad thing. Aerobic exercise, I'm gonna beat that to death. Folic acid is for something called hyperhomocystenemia, which is such a mouthful. But hyperhomocystenemia is too much homocysteine, and it is reduced by eating fruits and vegetables. You can measure homocysteine in blood. It's a very expensive test. And for my 2 cents, it doesn't really matter because you're going to tell the patient you need to eat more fruits and vegetables. And there's nothing wrong with telling people to eat more fruits and vegetables. So I personally don't measure it. So it's not rare, it's unusual, hyperhomocystenemia. And trans fat, bad stuff, just evil. 2006 was when they finally said you have to label things. So patients can look on labels to see if there's any trans fat in there. They say less than 1% a day, but 0 is actually better. So that's all the like diet and lifestyle stuff. After 6 months, then you do, if you're not getting to where you're going to get to, then you do chemotherapy. So there's a couple choices. Omega-3s are remarkable for what they will do to triglycerides. They do a little teeny tiny bit for LDL and cholesterol. It would not be my first choice, frankly. I think eating fish is great, but it wouldn't be my first choice. Red yeast rice contains a natural statin analog, lovastatin analog. It's pretty good. The problem with it is, the problem is not the right word. An issue with it is that it is not regulated by the FDA, as are any supplements, and so it's hard to know purity. It's hard to know if there's enough in it. What is the standard dose? Nobody really exactly knows how much to do. Garlic has lipid lowering. You have to eat a fair amount, a couple cloves a day to get it to go down, but it works. First line from the medical doctor is statin drugs. There you go. Second line is maybe the omega-3s and bile acid sequestrants, things like that. Prognosis for this, and then we're done, is that if you can get that LDL is what they target, right? If you can get that LDL down, you get a decrease in your cardiovascular events, mortality, so it's a good thing to do. If you don't, you will have accelerated atherosclerosis and you will die at a young age from usually a heart attack. Usually before age 50 for sure, sometimes before age 40, before age 20 if you're homozygous. So I was generous in thinking how far I was going to get because I didn't. But that's type 2A. I want to sum it up really quickly. Type 2A is familial hypercholesterolemia. Second most common of these. It's genetic. Comes in homozygous, heterozygous, and it's trouble removing LDL cholesterol. So the patient's LDL is high, patient's cholesterol is high. That's where you want to focus your energy. Quickie questions?
Is it only affecting mainly LDL?
The management of it?
No, the type 2A.
The pathology of it?
Yes.
Yes.
Okay.
So it's not going, you mean in a bad way?
I mean, just is it affecting more of the LDL in general?
It's only affecting.
Oh,
And so, and that would make cholesterol half that. But it doesn't affect HDL, it doesn't affect VLDL. Okay. All right. See you guys tomorrow.